Pancreatic pathology can be divided into congenital disorders, inflammatory disorders, and neoplastic disorders. Congenital disorders are relatively rare, but are pancreatic agenesis in which no exocrine or endocrine function exists, pancreatic divisum, which actually tends to be a very common but benign disorder, which results in the incomplete fusion of the two primordial pancreatic bodies. These patients are at risk for pancreatitis later on in adult life. Annular pancreas is also very rare, in which the head of the pancreas encircles a duodenum. This may cause duodenal obstruction later in life. Ectopic pancreas, in which pancreatic tissue exists in the stomach or the duodenum, is relatively common but a very benign condition. Acute pancreatitis has multiple causes, including choledocholithiasis, alcohol, hypercalcemia, hypertriglyceridemia, numerous drugs, and numerous infections. The two most common in the United States, accounting for approximately 90 to 95% of cases of acute pancreatitis, include gallstones and alcohol. Acute pancreatitis results in pancreatic acinar cell injury, leakage and activation of pancreatic enzymes inappropriately, enzymatic destruction of pancreatic parenchyma, fat necrosis, and hemorrhage. The complications include pancreatic pseudocysts, which are fluid collections and debris around the pancreas which are at risk for infection or hemorrhage, pancreatic calcification, in which calcium precipitates with free fatty acids and results in fat necrosis, as well as systemic complications including shock, ARDS, and/or DIC. Here's a picture of a CT scan showing a large pancreatic pseudocyst. Here are two gross specimens showing acute pancreatitis. Notice that the pancreas is swollen with hemorrhage on the left and fat necrosis on the right. Here are two pathologic slides showing acute inflammation with hemorrhage on the left. Notice the numerous blood cells, and fat necrosis. Here, notice the numerous lymphocytes. Acute pancreatitis usually presents with stabbing epigastric pain which radiates to the back. Lab findings include an increase in the serum amylase and lipase and an elevated white count. You can also sometimes see hypocalcemia or even increased hematocrit. Chronic pancreatitis can be seen in middle-aged alcoholics, but can also be seen as a complication of cystic fibrosis. Chronic pancreatitis is a chronic destruction of the pancreas. This can be the result of acute repeated bouts of acute pancreatitis or extensive parenchymal destruction with fibrosis from other etiologies, including cystic fibrosis. Here is a pathologic slide showing the chronic inflammation at the top. Notice all the blue lymphocytes, residual islets of Langerhans, and extensive fibrous replacement of the parenchyma. This can be caused by, again, recurrent bouts of pancreatitis, which results in exocrine deficiency as well as endocrine deficiency. If you have exocrine deficiency, you usually result in fat-null absorption or steatorrhea. Endocrine deficiency results in features such as diabetes mellitus. Islet cell tumors are tumors derived from the various cells of the islets of Langerhans. They are clinically significant because they secrete various hormones in an excessive, unregulated fashion. Most commonly, however, islet cell tumors are benign and don't secrete anything. Some, however, such as gastronoma and insulinoma, are associated with other conditions, including MEN syndrome, type 1. These tumors can be benign or invasive and/or metastatic. This pathologic slide shows an islet cell tumor. Notice the resemblance to normal islets. This slide summarizes the various types of islet cell tumors. The insulinoma, gastronoma, and vipoma are the ones to pay attention to, as these are the most commonly tested ones on the boards. Insulinomas result in unregulated production of insulin, which results in fasting hypoglycemia. Gastronomas secrete gastrin in an unregulated fashion, resulting in hypersecretion of acid and ulcers. Vipoma can result in a watery diarrhea, hypokalemia, and achlorhydria. Pancreatic adenocarcinoma is the 5th leading cause of cancer in the United States. It most commonly occurs in the ages of 60 and 80. It's an increased risk in patients who are smokers or alcoholics or those with chronic pancreatitis. The most common site of pancreatic adenocarcinoma is the head of the pancreas. These tumors arise from the ductal epithelium of the exocrine pancreas. It's associated with mutations of the KRAS and the tumor suppressor gene, the P53. Common complications include invasion of the ampulovator causing biliary obstruction, or invasion of the duodenal mucosa resulting in duodenal obstruction. Here is a picture of a pancreatic adenocarcinoma. Here is a pathologic slide showing the tumor with irregular glands and desmoplasia. Notice the normal pancreatic acini depicted in the slide above. All tumors usually present with abdominal pain and migratory thrombophlebitis. Tumors of the head of the pancreas typically present with symptoms of biliary obstruction, including painless jaundice and acolic stools. Tumors of the body and the tail, however, present with more vague symptoms, including pain and weight loss. They are thus usually diagnosed at a later time. The prognosis, however, is generally poor, with approximately 10% survival at 1 year. At autopsy, the pancreas of a 68-year-old male is grossly small and firm. Microscopically, there is extensive fibrosis and atrophy of the acini. Islets of Langerhans can easily be identified. Which of the following conditions best explains the autopsy findings? Partially penetrant cystic fibrosis, alpha-1 antitrypsin deficiency, chronic alcoholism, history of multiple blunt traumas to the abdomen, or cholelithiasis. The answer here is chronic alcoholism. This is what results in a small, firm, fibrotic pancreas. A 25-year-old female collapses at work. History reveals similar fainting spells over the last several months, described by the patient as a period of feeling faint, followed by a loss of consciousness. Given the microscopic findings, the best diagnosis is diabetes type 1, acute pancreatitis, pancreatic pseudocyst, islet cell tumor, or adenocarcinoma of the pancreas. This case should point you towards islet cell tumor, as the fainting spells are most likely hypoglycemic spells from an insulinoma. This concludes the section on